Good afternoon. I'm Robin Rontel, the Interim Executive Director for the Center for Health and Research Transformation associated with the University of Michigan and co-PI for the IDEAL RRTC. I'd like to welcome you to today's IDEAL RRTC webinar series from the Center for Disability Health and Wellness. We're delighted you could join us. Note that this event is made possible by a grant from the National Institute on Disability, Independent Living, and Rehabilitation Research. Today's webinar is entitled The Effect of Public and Private Health Insurance on the Use of Preventive Services for People with Disabilities. This webinar will be recorded, and the recording and slides will be available on our website sometime after the webinar. During this live presentation, please excuse any unexpected moments. We hope this doesn't happen, but if the webinar were to close unexpectedly, please reopen it from the link you used to attend this presentation. We welcome your questions. Please type in questions at any time using the Q&A box on the bottom of your Zoom window. We'll do our best to address all questions during the time today. Closed captioning is available. To show or hide the transcript, click the up arrow on the live transcript button that is also at the bottom of your Zoom window. Our presenter today is Elham Mahmoudi, PhD, who is Associate Professor at the Department of Family Medicine at Michigan Medicine. Dr. Mahmoudi, when you're ready, please start your presentation.
Thank you, Robin. Good afternoon, everyone. It's a pleasure to be here. Thank you, Robin, for the introduction. Let's just start without further ado. So this research project that I'm presenting today is about the influence of insurance type, public versus private health insurance specifically, on the use of preventative services and risk of potentially preventable hospitalizations among 3 different cohorts of adults with physical disability. So before I start, I would like to acknowledge my co-authors on this study. And we have no conflicts of interest to disclose. As Robin mentioned, this project was funded by NIDILRR. And this is the overview of my talk today. By the way, you can send your questions through chat, and I'll be more than happy to respond to your questions at any time during the presentation, or you can wait till the end. Either way is fine with me. So let me provide some background. As I said, our patient cohort for this study were adults with physical disability, and we purposely chose 3 cohorts of adults. One, adults with cerebral palsy and spina bifida, which, as probably you know, are congenital conditions known to cause an array of permanent movement disorders. The incidence rates are usually low, are relatively low in the United States, but life expectancy, fortunately, for adults with CP or spina bifida has been increased substantially over the last few decades. However, as we will see in the next few slides, these people struggle with higher rates of comorbid conditions, and they are at risk of adverse health events throughout their life. The second condition, or the second cohort of people we included in this analysis, were people with multiple sclerosis, which is a chronic inflammatory disease of central nervous system. It typically diagnosed or occurred between the ages of 20 and 40. So that's the difference versus congenital adults with congenital conditions. And the last one is traumatic spinal cord injury that can happen at any time. It's mostly caused by vehicle accidents, falls, or acts of violence. So basically, there's no probability of being diagnosed through life with it. It's a sudden traumatic event that caused the physical disability after the event. So let's talk about potentially preventable hospitalizations first. These are hospitalizations that could have been avoided if the patient has timely access to care. A good example would be a urinary tract infection. If I see my physician in the clinic or outpatient setting on time, as soon as I become aware of my issue, my urinary tract infection, I don't need to get hospitalized for that. Or the other example would be diabetes complications is another example. There's a set of conditions that are considered potentially preventable hospitalizations. They are defined by AHRQ, or Agency for Healthcare Quality and Research. I put some citations here because our group have done a lot of work on the area of potentially preventable hospitalizations. And in the supplementary files, we cited all the diagnosis code and metrics that are defined by AHRQ to basically identify potentially preventable hospitalizations. In short, PPH are commonly used metric of access to, quality, and efficiency of care, because if through the primary care setting, we can reduce the PPH, it's not only saving healthcare a lot of money because these hospitalizations are expensive, we also probably avoid potential harm to patients because of hospitalizations, such as infection due to hospitalizations, falls due to hospitalization, delirium, and so on and so forth. So they're not value-added services. It's true that we cannot avoid all potentially preventable hospitalizations, but majority of them are avoidable. So health insurance is an important enabling factor in access to quality care. Thus, one's timely access to care really depends on not only if you have an insurance or not, but also what type of insurance you have. I'll give you an example. While I'm all for Medicaid expansion, and that's the very first step that we need to basically fight for or ask for everyone for universal health coverage, we cannot fool ourselves by not acknowledging that this is not enough. For instance, you're all aware that many Medicaid patients are rejected by providers due to low reimbursement rate from Medicaid. So their access to care is not equal to people with private insurance and probably wider network of providers that they can go to when they have an ambulatory care condition. The other issue that I want to talk about, and our team and others have worked a lot on that, is the fact that the prevalence and incident rates of chronic conditions are substantially higher among adults with a disability compared to the adults to their counterparts without a disability. And that's due to basically their physical limitation in being active, the lifestyle, and everything else that we are aware of. So because of this higher need of this patient population, we need to ensure actually they do have a higher quality health insurance to enable access to preventative services to reduce the risk of adverse health event. So we know that research shows that among the general population, those with commercial insurance are at lower risk of potentially preventable hospitalizations compared with their publicly insured counterparts. However, there was no study, this one was the first, to basically broadly look at people with physical disability. We use those 3 groups of people as a proxy for people with physical disability to examine the influence of insurance on use of preventative services and on the risk for potentially preventable hospitalization. So that's the objective of this study, to examine the influence of traditional Medicare fee-for-service as a public insurance, because as majority of you know, people with disability, most people with disability, not all of them, will be eligible for Medicare before they turn 65, because Medicare is an insurance for older adults and for people with disability. Not all of them will be eligible, but majority will. Versus commercial insurance or private insurance. And for that, we used Optum claims data, which I'll talk about later in the data and method section of the talk. And the goal was to compare adults with the same type of disability, but different type of insurance. For instance, we compare adults with CP or spina bifida with private, and their counterparts or controls would be adults with the same type of disability, but with different type of insurance. And we do that separately for these three cohorts of adults with physical disability. So for data, we used 20% of traditional Medicare fee-for-service. These are claims data, administrative claims data, and 100% of commercial claims data through Optum Insight. So let me provide some examples, some explanation here for those of you who are not familiar with administrative claims data. Claims data in general are not developed for research purposes. They developed for billing purposes. They are basically the roadmap or middle ground between patient, providers, and insurer to basically enable the transaction, the healthcare transaction. However, they commonly used in research. They have pros and cons, and we'll talk about that in the limitation section of the talk. The good thing about them is we can measure all the healthcare encounters. We can measure chronic condition diagnosis, and these are the positive side about using claims data. Plus, we will have access through use of claims data. We have access to a large number of people with those identified conditions. So for this specific study, we used 2008 to 2016, two different types of claims data. And our patient populations for both of them were adults aged 18 and over with a diagnosis of either CP or spina bifida, MS, or traumatic spinal cord injury with 5 years of continuous enrollment. And we used 5 years because we used 1 year as a look back period and 4 years as a follow-up to look at our outcome variables during that 4-year look back period. And we pooled both data sets with the variables identified together to basically measure the exposure variable, the influence of insurance type on the outcome of interest. So again, our patient population, inclusion-exclusion criteria, people who died or switched to Medicare Advantage, MA stands for Medicare Advantage program during the year, were excluded from traditional Medicare fee-for-service claims data. So let me pause here and explain about the difference between the two, because we'll see in the sensitivity analysis, we'll come back to that. People who are eligible for Medicare can choose between Medicare fee-for-service, which is a traditional Medicare, that's why we use TM abbreviation for that, or they can choose to go for Medicare Advantage, which is a privatized version of Medicare. It runs by private providers and insurers, but funded by public account, which is Medicare, CMS in general. And there are differences between the two. There are substantial differences between Medicare Advantage and traditional Medicare. Just a very brief overview would be that Medicare Advantage, in general, they have different plans, but it's based on a capitated system. It's a managed care program, basically. And they're incentivized to keep the patient healthy. So they put more emphasis on the preventative care services versus providing services at fee, which is the condition in traditional Medicare. We'll get back to that. But for inclusion-exclusion criteria, we excluded people who were in the MA program or Medicare Advantage from traditional Medicare data because their healthcare encounter is not included in Medicare claims data, and we have incomplete information. The look-back period was defined based on 365 days before the first disability diagnosis for each of those three conditions that we identified. And we did that to define our one-year look-back period. And we used that look-back period to identify chronic conditions and comorbid conditions as a history because there will be covariates in our model. At the end, we excluded from both data sets individuals with end-stage renal disease, with pregnancy or cancer diagnosis. And we did this because AHRQ, or Agency for Healthcare Quality and Research, exclude those conditions when they were measuring potentially preventable hospitalization, because we don't want to include these people are at higher risk of hospitalizations because of their condition. So we didn't want to make the results biased. So that was kind of summary of our inclusion-exclusion criteria. And as you can see in this slide, for each of these three cohorts of adults with physical disability, these are the numbers, which are healthy, large numbers of for quantitative analysis. I mean, for people with public or Medicare fee-for-service insurance versus our controls with private insurance, again, for each of the three different cohorts that we examined in this study. So this is a list of our outcome variables. Any occurrence of potentially preventable hospitalizations during the year, and any use of the following preventative services: annual wellness visit, bone density screening, cholesterol screening, diabetes screening, and physical and occupational therapy. And let me explain the rationale basically for these outcome variables. Well, PPH, I think it's clear, is a quality metrics, and that's why we included it. Use of preventative services, the most important one is the annual wellness visit. And let me explain that since 2010, after Affordable Care Act, there is no out-of-pocket cost associated with this annual wellness visit, regardless of your insurance. It doesn't matter if you have public or private insurance. As far as you have insurance, there is no out-of-pocket cost. And this would provide a patient a chance to see his or her primary doctor and basically identify the risk factors before they get serious. Not too many people use these annual wellness visits. It's an important indicator of preventative care, and that's why I included them here. The rest of them are basically here: bone density screening, cholesterol, diabetes, PT/OT, because people with physical disability, we know that they have a higher rate of cardiometabolic conditions, musculoskeletal conditions, and they are in need of these services. They're both preventative and well-being services for this specific patient cohort with physical disability. And this is a list of our covariates, explanatory variables that we included: age, sex, race, ethnicity. Elix-Hauser comorbidity count, for those of you who are not familiar, is a list of about 31 chronic conditions. Obviously, the higher the number shows that you're at higher risk of adverse health events such as PPH, because you have more to deal with. And we also included diagnosis of certain comorbid conditions in our model. And in our PPH model, we also included if the patient has used any of those preventative services, specifically annual wellness visit, because we wanted to see, and that would be in our results, if annual wellness visit can reduce the risk of PPH among this patient population. And we also control for US Census Division. Our exposure variable, again, was the insurance type. So for each cohort, we have 3 cohorts of people to compare them with those with public versus private insurance. And for each outcome variables that I defined earlier, we ran a separate generalized estimating equation model, and we used this model to address the repeated measures because it's a longitudinal analysis. It's a closed cohort longitudinal analysis. We followed these individuals for 4 years, basically, after the look back period to measure these outcomes. We conducted 2 sensitivity analyses. The first one, we wanted to look at Medicaid eligibility. As you noticed in our explanatory variable, we didn't include any socioeconomic status. And this is kind of untypical work for us because as an economist, I love to include socioeconomic status in our studies because, especially for potentially preventable hospitalizations, it's not just the medical issues, it's an access issue. And we know that socioeconomic status would influence your access to care. But because of the view of the Optum Insight, we didn't have access to basically the zip code of our patient population to merge it with other public data that we usually do to include aggregated data for socioeconomic status. Anyway, it's a longer story to say why we focus on Medicaid. In Medicare claims data among those with public insurance, we know who people who have lower income and fewer resources might be eligible for Medicaid. So they call them dual eligible. Those people with dual eligibility status have lower socioeconomic status and might be at higher risk. And we want to compare them with those with non-dual eligible status. So that was the first sensitivity analysis. The second one, we wanted to also compare Medicare Advantage with Medicare fee-for-service, as I spoke about it earlier. So we limited our study in this sensitivity analysis to adults 65 and older. And those who were in private insurance in Optum had Medicare Advantage. Again, these are people with the same type of disability, and those in Medicare 65 and older are with have Medicare fee-for-service, so we could compare Medicare Advantage with Medicare fee-for-service. So let's jump into results. I'm going to pause and see if there are any questions so far before I jump into going over the results. Sarah? Or
there are no questions at this time.
Okay. So let's move on. The first table I want to show, and I apologize for all these numbers. Nobody likes crowded table with a lot of numbers in it. What I wanted to present here, and these are characteristics of people with cerebral palsy or spina bifida. Nothing important in here. I just highlighted 2 sections that I thought is important. I just wanted you to see and compare characteristics of people with CP or spina bifida overall and those who enrolled in private insurance versus those in public. 2 important things just basically jump out. One was the rate for female. In general, we have about 50% of our population among the people with CP or spina bifida are female. Majority of them are have private insurance. That was one thing, and that was kind of similar theme among other people with other type of disability. And the other thing that I want to point out, despite the fact, because I want to show you that we are not comparing apples and oranges here, Elix-Hauser comorbidity count is about the same for people with private and public insurance. There's no statistical difference. There are some differences in a specific chronic conditions that we also included in our model, but overall, we didn't see large differences in health status of these people with private versus public insurance. And I'm just going to show you what I have for CP and spina bifida for characteristics, because the rest for people with MS and TSCI, the results were the same. This table, on the other hand, is basically the meat of the findings of this research. So let's pause on that and go over the results. These are, I listed all the preventative service use for each cohort of basically our patient population, CP, spina bifida, TSCI, and MS. You see them in the gray row. The columns, the first columns define the crude rates or unadjusted rates for use of these preventative services among people with private versus public insurance. And the last column shows the adjusted odds ratio of having a public versus private insurance for the use of each of these preventative services. So one common theme, again, don't worry about the numbers because the story is the same. If you look across, you can see that people with private insurance, regardless of their disability type, use higher percentage of them use preventative services compared with people with public insurance. The difference, though, is statistically significant, but there's not much difference in the crude rate. It's higher in private compared with public insurance, but the difference really is not that big. When we adjust, though, the adjusted odds ratio, adjusting for all comorbidities, age and sex and etc. that I showed earlier in our model, we see a relatively large number creating, like, I'll give you an example. For instance, among people with CP or spina bifida, people with public insurance, if you look at this number here, adjusted odds ratio, were about 16% had lower probability of getting their cholesterol checked annually. That's what it means. Or for diabetes screening, it's about 8% lower among those with public versus private insurance. However, what I wanted to emphasize here is annual wellness visit. Remember, for both people with private and public insurance, there is no out-of-pocket cost associated with this event. However, look, the difference is really substantial. 26% of these people with private insurance versus about 10% of people with CP spina bifida with public have an annual wellness visit. They go for their annual checkup. Or when we adjust our model, basically the probability of someone with CP or spina bifida with the public insurance is about 70%, 70% lower to have an annual wellness visit compared with his or her counterpart with the same person with CP or spina bifida with private insurance to have an annual wellness visit. That's a huge difference. And the same for physical and occupational therapy. That's why I highlighted these two throughout for all three cohorts. The differences are substantial. For example, again, among people with CP spina bifida, PT-OT, 25% of those with private insurance versus about 15% of those with public insurance have any PT-OT during the year. Or if we adjust our model, the chance of someone with CP or spina bifida with public insurance is 50% lower than someone with CP or spina bifida with private insurance to have a physical or occupational therapy. And we know these services are important for these people because they have physical disability and that helps them with the movement and everything. So, and that's the story that that's a repeated theme, as you can see. Most of them are statistically significant. Again, for annual wellness visit and physical occupational therapy, the differences are substantial. And then we look at the risk for potentially preventable hospitalization. The same story repeats. For each of these cohorts that we have, crude rates or unadjusted rates for private and public are listed here. As we can see, consistently, the risk for PPH among those people with public insurance is substantially higher compared with their counterparts with private insurance. And the odds ratio are the same. For instance, for people with MS is substantial. Someone with MS with public insurance is more than twice at risk of PPH compared with the same person with the same conditions, adjusted for all those variables with private insurance. That's, again, a substantial difference. And I want to show the effect of annual wellness visit, which we talked earlier. As you can see, regardless of your insurance, public or private, having an annual wellness visit among all these three populations, CP, traumatic spinal cord injury, and multiple sclerosis, it reduced the risk of PPH. For people with CP or spina bifida, it reduced it by about 20%. Among people with TSCI, it reduced it by about 25%. And among people with MS, having an annual wellness visit reduced the risk of PPH by 40%. It's a huge percentage. So think about an investor. If we try to make healthcare more efficient and increase the quality of care, annual wellness visit that once a year complete checkup worth a lot, because it can reduce the risk of these hospitalizations that are expensive and harmful. That's, I think, the most important message off of this study, basically. So I'm going to go for the sensitivity analysis that we did. The results make sense. They're not surprising. The first one is a comparison. We looked at those people with public insurance. These are all our Medicare enrollees with those defined conditions. Multiple sclerosis at the top, TSCI, and then CP or spina bifida. In all three of them, being a Medicaid enrollee or being dual eligible compared with non-dual eligibles increase your risk of PPH. So how to interpret this? Basically, your risk, if you're dual eligible, is 80% higher if you have MS, about 60% higher if you have TSCI, and 47% higher if you have CP or spina bifida. We'll discuss this in the policy implication of it. Again, remember, that's an indication. Just having the insurance is not enough. accessibility is more than insurance. And the other sensitivity analysis that we did was comparison between Medicare Advantage for older adults with those disabilities compared with fee-for-service. Again, people with fee-for-service are at higher risk of potentially preventable hospitalizations compared with Medicare Advantage. However, if you look at these results, in order for it to be statistically significant, the confidence interval is 95% confidence interval. It has to be between above 1, basically. It shouldn't cross the 1 line. It only came significant for multiple sclerosis. Basically, what it means that people with multiple sclerosis who have Medicare fee-for-service are at 61% higher risk of PPH compared with their counterparts with Medicare Advantage. However, the risk for people with traumatic spinal cord injury and CP or spina bifida did not come statistically significant, though it shows that it's significant. We don't know if it's by accident or it's a systematic difference between the two groups. So let me go over limitations. Again, if you have any questions, we're done with the results. Please ask your questions. Limitations basically goes back to the nature of the data for this study. Claims data have their pros and cons, as I mentioned at the beginning. The limitations of claims data is the lack of granularity for socioeconomic status. They were developed and designed for billing purposes, not for research. They're different from surveys such as medical expenditure panel survey or health and retirement study. However, we do have access to larger population. We can objectively measure healthcare encounters, and we can objectively identify chronic conditions using them, but they don't include a good indicator for socioeconomic status. The results may not be representative of the US population because what we use for private insurance, there are variations, large variations among private insurance. We only use Optum Insight data, so that's not generalizable. And the other important thing is using claims data, we don't have any measure of severity of these physical disabilities. It is plausible that people with lower resources and more severe condition probably enrolled in public versus private insurance. However, we adjusted for the variables we could control for, but that's the limitations that we couldn't address because we didn't have any measure of severity of the condition. So in conclusion, people with private compared with public insurance had higher odds of receiving preventative care and were at lower risk for potentially preventable hospitalizations. Older people with Medicare Advantage plans used more preventative services and were at lower risk of PPH than people with traditional fee-for-service Medicare. And in Medicare fee-for-service only, dual eligible adults, this include people with Medicaid, people with low resources and income, had lower use of preventative services and were at higher risk of PPH compared with non-dual eligible adults. So policy implications. In general, adults with disability are more likely than the general population to delay or forgo necessary medical care, and it's due to perhaps poor care coordination for this patient population, inaccessibility of some of these clinics, or inaccessibility of preventative services that are mainly designed for enabled people, not for people with disability, or financial difficulties. We know that people with disability, because of their condition, might have more financial difficulty compared with other adults. Our prior work shows an elevated risk for potentially preventable hospitalizations among adults with disability compared with the general population. That's not surprising. In this study, what we found was people with private, basically more generous, higher quality insurance have better results with the same type of disability compared with those with public insurance. And private insurance in general, many of them work based on a capitated model. They are designed to operate more efficiently, meaning that when the payers realize that hospitalizations are more expensive, they provide incentives and systems to encourage more and higher use of preventative services. I give you an example. I receive a letter when it's time for my annual checkup. That's a reminder. That's an incentive. I don't forget. When it's time for my mammogram, I receive a letter. These are all incentives. Perhaps we do need to do a better job for people with disability with these incentives to encourage them to use these services, to come for their annual checkup, to do these screenings ahead of time. To have better access to preventative services and reduce the risk of PPH. Again, this is something I mentioned at the beginning. Having health insurance is the very first step, but it's not enough. High-need patient population, such as those with disability, need affordable but high-quality insurance. And perhaps this study wasn't about the cost analysis. Probably that would be a good future study. It seems that it can save costs if we provide more higher quality insurance to be able to prevent these expensive and not value-added hospitalizations. At this point, I would like everyone to please fill out the evaluation form. I provided the HR code here. It's just 3 or 4 questions. It doesn't take more than, honestly, 1 or 2 minutes. And here is the link. I can also, when I stop sharing, I can put this, or Sarah, if you can do that, we can put it in the chat. I would appreciate if you fill out the evaluation form for the webinar. And that's it. I open the floor for any questions you may have. And here is my email address, by the way, if you have any questions, if you're interested to participate, feel free to email me at any time. Thank you.
So actually, we do have a couple of questions that came in. So the first one is, what can be done to expand access to preventive care for people on Medicare? It seems that providers refusing to take Medicare is one of the biggest barriers.
Yeah, that's a great question. Yeah, that is a dilemma. The same issue that we have with Medicare, we have with Medicaid. It's more pronounced for people with Medicaid because the reimbursement fee is even lower in Medicaid. I honestly don't know the answer to this question because it's complicated. On one hand, we cannot, I know Medicare is under a lot of financial pressure as of now. The population is aging and they have financial difficulty as it is right now. So increasing the fee for providers, Medicare providers, I'm not sure if it's sustainable or not. That would be one way, or providing other incentives for providers to accept Medicare beneficiaries. that's something that we need to discuss. The same issue exists, and I don't have a good answer for that. For Medicaid, we know the budget for Medicaid is very limited. There is a reason for low reimbursement fees because Medicaid cannot afford anything more than that. However, it has consequences. One answer would be, and these are just hypothetical, plausible answers, not based on research, my own opinion. If we can cut back on services that are not efficient, perhaps we can increase the fee for providers and that way provide incentive for providers to accept these people. One thing that I've seen in other countries, they have done providers, again, it goes back to all the problems. It's a long answer to a short question. With our healthcare system, if we had a universal health coverage, each provider had to accept you regardless of your insurance. And that's how it's run usually in most developed countries. But with our kind of hodgepodge system of systems of healthcare in the United States, providers have the privilege of accepting or rejecting patients, and that is not right, and it's not easy to be addressed.
Absolutely. Thank you for answering this question. We also have one other. It says, so it looks like the gap in preventive care between folks on public and private insurance was notably higher for people with MS compared to people with TSCI. Do you have any theories as to why?
I'm sorry, Sarah, can you repeat the question again?
It looked like there was a gap in preventative care between folks on public and private insurance, and it was notably higher for people with MS compared to people with TSCI. And do you have any theories as to why?
Yeah, sure. Lots of people, again, these are not based on research. Most of it is hypothetical, but many people with MS are not eligible for Medicare as we see among other people with disability. For instance, people with CP or spina bifida, I know are among physical conditions that would be eligible for Medicare. MS develops later in life, in their between 20 and 40, or later in even after 40. So the fact that people with private insurance probably have established connection, maybe they were employed, and that's how they received their private insurance before the diagnosis of the condition, and they could continue using that, might be a factor. In general, it could be, and this is not specific to MS, but could be for both CP, spina bifida, TSCI, and other physical disabilities, difficulty in accessing these clinics because of difficulty of movement among these people could be a reason. And basically having the bare minimum insurance, especially among people with MS who develop the condition at the middle age, might be exacerbate their use of preventative services. And let me explain that, because I compare that with among people with CP or spina bifida. There's a lot of research has been done, and it's a good thing. We need to also mention the good things. I know that among kids with CP or spina bifida, we have done a lot of progress. We have a lot of progress in our healthcare system, providing their access to care till they turn as an adult. When they turn adult, so the system for children with CP or spina bifida is well established and is working well. However, when they turn adult, as an adult, we kind of lose them. Many of them might have an insurance, but they did have established period of time to access these services versus people with MS, they develop their condition at the middle of their like prime time, and they might not have that established connection with healthcare system before. That might be a reason of the difference between the two groups. But again, these are my own opinion, hypothetical reasons.
Yes, thank you so much for the answer. So we actually have one more question. Should patient advocacy and or professional groups representing and serving high-risk populations, such as TBI, SCI, MS, cardiovascular conditions, work together to gather data on patients similar to that in this study and share published set standards to improve care and reduce higher cost hospitalization and risks?
Yeah, I think yeah, absolutely. I think what we need to do, that would be an interesting future study if someone is interested, to show the cost difference, really. That would be a really cool study, because my assumption is cost of preventative services is much lower than hospitalization and adverse event, emergency visits, and PPH and hospital readmission and so on and so forth. So, and what I've learned in healthcare policy, again, this is unfortunate fact about our healthcare system. If we can show that providing a higher quality insurance with more access to preventative care, value-added services, is also can also save money for healthcare system, then I think we have someone to listen to us. So yes, absolutely. I think that's the way to go. And we should just, this would be a very good future study from the current, based on the current literature on this topic.
That's great. Thank you. So I don't see other questions.
All right. Well, thank you everyone for listening and for joining us in this webinar. Thank you, Sarah, for hosting.
Thank you. So thank you so much to Dr. Mahmoudi for participating and to the audience for joining us and sharing your questions. So like I said before, please provide your feedback about the webinar and the Qualtrics survey that you will be receiving after the event. And this event is being recorded, so the recording and presentation slides will be made available and accessible as soon as possible. So I hope you have a great rest of your day, everyone.
Thank you.
Goodbye.
Bye.